So good afternoon and welcome to today's session. Thank you very much for joining us. My name is Sally Leech. I'm from Henpicked and Henpicked Menopause in the Workplace. I'm delighted to be here today with Dr. Karen Morton to talk about HRT after cancer. So Dr. Karen Morton is a consultant gynaecologist, a menopause specialist, and works both within hospitals and also runs an online service to provide easy, accessible support for people in Dr. Morton. So Dr. Karen, welcome to today's session.
Hi there, Sally. Nice to see you.
Lovely to see you. So today's session is very much in answer to, we get a lot of questions frequently asked around the benefits and risks of HRT, but in particular, what are the options available for people who either have had cancer or have a genetically higher risk of cancer, or those who are experienced induced menopause due to treatments they're going through. And so firstly, just wanted to start with that question around, for somebody who's been through a cancer treatment or is genetically at high risk around cancer, what are the considerations around whether HRT may be possible in terms of managing menopause symptoms?
Okay, well, Sally, of course, that's actually too broad a question, if I may say
Cool.
so,
Yeah.
because cancer can cover a multitude of things. I think most commonly, of course, people are talking about treatment after treatment for breast cancer. Or with a high risk of breast cancer. That's really what the question centers around. I'm very happy indeed to cover a whole range of cancers, because of course any cancer is it's a hugely difficult experience. But there are many types of cancer for where hormones have no bearing on it at all, and women can take hormone replacement therapy when the time comes with impunity. It's not going to affect their prognosis, the outlook, the likelihood of recurrence at all. So I will touch upon others, other gynecological cancers, for example, but usually when people are asking this question, it's to do with breast cancer.
And I think that's a really important thing to understand, because there is this broad brush statement of when somebody has experienced or going through cancer treatments.
Yes.
But as you say, there's such a broad experience people can have in different types of cancer. So I think it's a really great thing to have started to identify to start with.
Okay. So I think perhaps to start with, we'll talk about breast cancer then, shall we? Absolutely. Okay, so obviously breast cancer is a very, very common disease that we all have a 1 in 8 lifetime risk. Of course, if it comes in much later life, then it's very unlikely that that woman will be continuing with HRT. She might be one of those ladies who's going to take it forever, but the commonest symptom for those older women is vaginal problems, and it's perfectly fine for them to be using local estrogen. It depends a little bit on what their ongoing treatment for their breast cancer is. But let's go to the younger age group, the real youngsters. A typical case would be a lady I saw last week, a lady of 44 who's just completed her breast cancer treatment. She's had radiotherapy, chemotherapy, and she's been plunged immediately into menopause. She never took HRT. That was not on her radar yet. She was having regular periods at that time. She has young children. Her main symptom at this moment in time actually is not hot flushes or other things, but it's anxiety. Of course, this lovely woman has got every reason for she's in grief. She's grieving for the awful situation that she has been faced with, and she's terrified for her children. So she has every reason for this anxiety, which may in part be related to hormones, but it may well be in part because she's had this polaxingly distressing experience, which is ongoing, and with time will pass as she becomes further away from the diagnosis. But for that particular lady, the right treatment for her at this moment in time is something to deal with the anxiety, but which may well help with hot flushes. She is having some hot flushes, and that's just a terrible nightly reminder, moment by moment reminder of her situation. And so that woman, I have started her on venlafaxine, which is it is a neurotropic agent. It's an anxiety medicine, but it can be very helpful for hot flushes as well. And of course, the trouble is that anxiety fuels the hot flushes. And so I think that that's the right treatment for her at this moment.
And I think that's what, we certainly hear from many people. We've had people in tears on sessions saying that I'm experiencing all these things and I just don't know what to do.
Yes. So that's the young woman who's right in the throes of the experience of breast cancer. There's somebody on the chat who said, what's the name of the drug? It's venlafaxine. Then there are women who develop breast cancer on hormone replacement therapy. So these will be women usually in their 50s, maybe their 60s, but their 50s usually. And it's very important, first of all, that they don't think that they've caused it by taking their hormone replacement therapy, because the evidence about that is pretty crystal clear now, that estrogen alone, natural estrogen, does not increase the risk of breast cancer. It is true that the synthetic progestogen that is in most combined preparations after several years of usage has a very small but statistically significant effect on the incidence of breast cancer. But by and large, breast cancer is a disease which has come because it's going to come. So women do not need to feel that they've caused it. We'll come perhaps to the ladies who feel they've got a genetic predisposition to it, either through BRCA gene or a strong family history. So there is no right answer for these women, and one of the difficulties with the science behind it is that it's almost impossible to conduct randomized, placebo-controlled trials in these circumstances. Let me explain exactly what I mean. The only scientific trials where medicines are concerned that is really worth its salt, can be evaluated, are randomized, placebo-controlled trials. That means that neither the person who's taking the medicine nor the researcher knows whether that woman is taking the active medicine or a placebo, just a mock-up. It looks exactly the same. And it's just not possible to research those things. You couldn't mount the ethical approval to do such studies. It wouldn't be an ethical study. Yeah. So, of course, it will depend partly on the receptor status of the tumor. So when a breast cancer is treated, it's sent for analysis of whether it has estrogen receptors or progesterone receptors or both, and various other fine details. But by and large, if a tumor was estrogen receptor positive, the oncologist and the breast surgeon, they are two separate people, a part of the team that are looking after the breast cancer, they will feel that there is a higher chance of recurrence if the woman takes hormone replacement therapy. Now, these people are kind, caring doctors, and they will listen carefully, I'm sure, to how a woman is feeling, how she's experiencing, what she's doing, how she's getting on, how she's living her life. And there isn't an absolute rule. Nobody would say, you cannot. They would say, I would feel concerned about the increased risk of recurrence. So let's try everything else that can be tried to see if your symptoms could be helped by other means. So that might be the medicine that I've mentioned. It might be that this woman's main worry is the health of her vagina, It is usually possible, depends on what, I'll say a word, and because it's a word people will have heard, what adjuvant therapy women are on. So having had surgery, radiotherapy, chemotherapy, many women will then be on adjuvant therapy, which is a medical treatment, a tablet, which everybody will have heard of tamoxifen. Many people will have heard of of letrozole, of anastrozole, so the aromatase inhibitors. That's a group of medicines. On tamoxifen, it's perfectly possible to take vaginal estrogen. On the aromatase inhibitors, it's not. But there are other medicines that can be used vaginally to maintain vaginal health. And I'm very keen on a medicine called prasterone, which is actually a male hormone. It's dehydroepiandrosterone. It's a male hormone, which is given as a pessary into the vagina. And it is absorbed by the vaginal tissues. And within the cells, the actual cells, so intracellularly, it is converted to estrogen and testosterone. And it's really good for vaginal health and bladder health, and less than 5% of it gets into the general circulation. So the oncologists and breast surgeons are by and large being introduced to this approach to vaginal health, and they're happy with it. If a woman's symptoms are really bad, so she feels her quality of life is just, she cannot live a happy life as she is, then of course, that's a balance of risk, and she must, with explanation and discussion, she must make her choice. But nobody would deny her hormone replacement therapy if she feels that her quality of life cannot be sustained without it.
And for somebody who's finding that they're not getting that support from their gynecologist or their oncologist or their breast surgeon, and they're finding they're not getting that, they're not feeling they're being heard around that, what advice would you give to somebody to try and get across what it is they're feeling and what help and support they want?
Well, I think they need to approach it explaining that they have researched it, that I've done my research. That's an expression one hears so much more these days. I've done my own research. I understand that there may be risks involved, but for me as a person, my quality of life is poor and I want to address it. And I have decided that I am prepared to take that extra risk. And that extra risk can't really even be quantified, but it will be real.
Yeah.
So you'll hear what I call extremists. You need extremists almost to find the middle ground. And there are some people who say, of course, it's fine. It's absolutely safe. And I don't believe that for a minute. And there'll be others who say, under no circumstances must this woman take. And they are extremists. And we should hear them and then park them to one side and try and find the middle ground, working with the woman with other possible therapies. And we all know, for example, that CBT, cognitive behavioral therapy, which actually was researched in men who were receiving treatment for prostate cancer, because they will be taking medicine that will block all estrogen in their circulation. Men have estrogen too. And it was in this group of patients that Myra Hunter researched the positive benefits of CBT for hot flushes. And I know that if I was sitting here now having a hot flush, I would be feeling a bit anxious, and my anxiety would fuel the hot flush. And I would think, oh, I can't do this anymore, help. But we can break that vicious circle with a CBT training. So there are lots of other ways and lots of dietary manipulations that can be helpful. And so exploring all avenues is very important.
Absolutely. You mentioned around for those who feel that they are or have been said to be genetically at higher risk around,
yes,
in particular breast cancer. What key considerations should they have in making decisions around treatments?
Well, it's true that we know so much more about our genetics these days, and the BRCA gene is a well-defined thing with whole families with predispositions. And if you've had a close family member who has had a breast cancer, most women in that circumstance, most, not all, but most, will feel that they will take an alternative approach with dietary manipulation, other non-hormonal medicines. But the same really applies to those women as to those ladies who are really having a terrible quality of life and they feel they're prepared to take that risk. A small, statistically significant, unquantifiable risk, and they must decide for themselves with guidance and with support.
Excellent. And in terms of other types of cancers, you mentioned other cancers that we might want to consider when we're thinking about treatments around menopause and in particular around HRT.
Yes. So probably the most important one to mention is women who have had cancer of the lining of the womb, endometrial cancer. So endometrial cancer is a common cancer, particularly in older women, but it can occur in women in their 50s, 60s. It is largely due to overstimulation of the endometrium by estrogen, and it's commoner in women who have risk factors for anovulatory cycles, non-egg producing cycles. We know, for example, that when HRT was started in America, all those years ago, decades and decades ago, women were just given estrogen, and it was then that we learnt that they developed endometrial cancer, and so it was through that observation that we learnt that women who have a uterus must take a progestogen as well. They must. And in fact, interestingly, you'll be interested to know that the incidence of uterine cancer, endometrial cancer, is actually significantly lower in women who take a combined HRT regime compared with women who take nothing. So it's actually positively protective. But back to the woman who's had an endometrial cancer, there is evidence that the risk of recurrence is increased if they continue to take HRT. So unlike women who've had a hysterectomy and can take just estrogen as their hormone replacement therapy, women who have had an endometrial cancer would definitely be advised not to take estrogen for at least 5 years. And after that, 5 years would be considered a cure. And after that, they can make their choice. So they would be advised to use the same sort of ways of remedying symptoms as the women who've had breast cancer.
Fantastic, thank you. Just going to bring my colleague Sarah on because I can see we've got lots of questions coming through. So Sarah, if I can pass over to you.
Thank you, Sally, and thank you, Dr. Karen. Yeah, we've had an awful lot of questions coming through. Actually, the chat's been going mad, and there's been lots of support, as we always find, Sally, in these sessions, support for each other. And you'll love this one, Dr. Karen. There's a few people who are really sympathising with each other and wanting to create their own support group, which is lovely. So I'll come on to a few of those questions in a moment. But in general, what I'm getting is general sense of what people are asking. They're always being told no to HRT. So what are the kind of questions, that they should be asking? What advice would you give for them to go back and really try and, not fight for what they need, but get the right questions asked and really help them?
Well, I think the first thing to do is to ask some questions of themselves. And to ask themselves, what are my top 3 things that are bothering me? Because if you can break it down rather than just have it as, I've got dreadful menopause symptoms, I think it can be really helpful because each individual major issue may be able to be addressed individually. So I gave the example earlier of anxiety. I feel very sad when I hear some women dismiss the possibility of taking I'll put them under an umbrella of neurotropic agents. And sometimes people are rather dismissive of, my GP tried to fob me off with an antidepressant, or my whatever. One hears it all the time. I know you must do as well. Where sometimes actually what is needed might be an antidepressant. If it's properly thought through and discussed and understood, it may be that is what is needed. Or an anti-anxiety medicine. It may be that is what is needed. If it is poor sleep, it may be that something else could be useful for poor sleep. There are, so the top three things, if it's vaginal symptoms and worry about that they've been vulnerable to UTIs in the past and they don't want to go back to that being the case. So analysing it and breaking it down and then presenting that these are my top three concerns. Can we please work out how we're going to deal with these? Because they're spoiling my quality of life dramatically. So I think that would be my first advice. Ask it of yourself first.
Super, that's really helpful. Thank you. And a few people have mentioned, we touched on the herbal remedies. Is there anything that you'd recommend from a herbal perspective that people could take? There was quite a few examples earlier where people were saying, would they react with my tamoxifen, and what herbal remedy could I take?
Yes. Nothing really will react with tamoxifen, but they can be troublesome with the aromatase inhibitors. Unfortunately, none of the herbal things have stood up to randomized trial scrutiny, which is disappointing. Of course, there is a lot of plant estrogen about, and adopting the sort of diet that a Japanese lady might eat is very helpful. But I can't truthfully recommend specifically a herbal thing or starflower or black cohosh or whatever. And I've found that women's responses to these things is very idiosyncratic. So I'm not in any way against taking them, but I think it's a personal trial.
I just wanted to add a question here that has come up a few times around vaginal dryness and that being a symptom. And someone was just checking what are the symptoms of this, because they kind of feel they've got itchiness, but there's no discharge or anything. Is that likely to be that's what that could be? And is it something you can treat over the counter? Is it something you need to get prescription for? And just getting some guidance around that.
Okay. Itchiness could be all sorts of things. It's not likely just to be estrogen deficiency. It might be, but on the whole, I would want to exclude other things first. Obviously, common things are common, and a lot of women will be self-treating for thrush endlessly, and actually it wasn't thrush at all, or it might have been thrush at the beginning, and they've been left with a sort of dermatitis-y, sort of eczema-y, sort of dry, cracky itchiness, and they might need a steroid ointment. They might even have developed a primary skin disorder of the vulva, something called lichen sclerosis. So I think if they've self-treated for thrush once, which they usually have, and it's still there, then they should go and be seen and be examined to make sure there isn't some actual skin disorder. And then after that, I think it is worthwhile using local nutrition in the form of a hormonal treatment. And I've mentioned my favorite, prasterone, which I'm afraid is not on the green list of most GPs. By the green list, I mean that they're allowed to prescribe it. It will come, but it takes ages. I mean, I'm working hard in my area to get it onto the green local guidance, so that GPs will be able to prescribe it. But probably to start with, it would be better to see a gynaecologist and have it prescribed, and then the GPs will likely to continue with it.
The people are asking how you spell that, or what's it called again? Prasterone,
Prasterone. Its trade name is Intra Rosa.
Brilliant. That's brilliant. I think that's really helpful for people. And I think there is that frustration of certain things that you I'm sure for you as a clinician, things that are going to help people, and it's hard then to access. I think that's a frustration many people are coming through with. Any additional questions, Sarah, that you wanted to add on?
Yeah, I think a few people have mentioned acupuncture. Dr. Karen, any views on that? It sounds like it's helped some people.
Yes, no, I think acupuncture can be very helpful. Again, I don't understand acupuncture, but I've witnessed people having major operations just with acupuncture. So it is an extraordinary science, isn't it? And although I'm not expert in these alternative approaches, I'm not at all dismissive of them. So I think it's a good thing to try.
Yeah, absolutely. I'm just trying to look and just see any final questions that we've got. We've got a few specific examples. So, for example, someone's after estrogen-based DCIS, which removed from a lumpectomy, really struggling with menopausal symptoms. And so I guess this is going back to exploring what symptoms those specifically are, and then starting to tackle those one by one. I think that's a really interesting way of approaching it. Something I know we talk about in general with menopause. When you get specific, it becomes easier to start to work your way through those.
Yes, as opposed to my life's a mess, I'm never going to get going again. That's not it. And for example, fatigue would be a very common symptom, wouldn't it? And everybody should be taking a vitamin D supplement, and just looking at making sure that it's not their thyroid, it's not make sure you have a general health check for fatigue. Don't assume that it's just menopause.
Yeah, absolutely. There's a good question just coming around. Sorry, just coming around. Any advice regarding breast density risks for breast cancer and HRT?
Well, we know that dense breasts are at higher risk, but I think as long as one is self-examining and having mammography at the appropriate time, it's a personal choice. It's a bit like those ladies who have a genetic risk. Yes, you need to be really vigilant about it, but it's not an absolute no by any manner of means. But maybe look at those or other alternative approaches if you feel. Different people handle risk so differently. Some women will have their dense breasts and think, well, okay, well, I understand that, but they remain bright and breezy, and they feel they can handle a little extra risk. And others are completely and utterly risk averse, so individual. And every woman must be treated as an individual, talked through the issues with respect, taking account, not imposing one's own views, but just listening and hearing and seeing where the woman's her philosophy. You've heard me say that so many times, Sally. The whole thing about it, HRT is a philosophy, and this is just another personal philosophical issue, isn't it? Where do I sit on these risk issues?
Yeah, absolutely. We've got one particular around where to go to advice around HRT after a clot. And I know we're not talking about clots in particular. We're just wondering, I know there's different types of HRT, key considerations for that, just because it's come up in the questions.
Well, if it depends on the clot, and it depends on whether a woman is maintained on anticoagulants thereafter. But in truth, by and large, transdermal estrogen doesn't affect clot risk.
Absolutely. And the final one is just around the Mirena coil, whether that's still okay post an ER positive breast cancer.
Well, it's interesting because tamoxifen has a partial stimulatory effect on the endometrium. So one does actually see women on tamoxifen develop womb lining thickening and sometimes polyps, and even a very slight increased incidence of uterine cancer. And the Mirena can counterbalance that. But if they are progesterone receptor positive, then their breast surgeon will say to take it out, even though it will be an incredibly tiny amount that goes into the general circulation.
And just a final question, who would you say is the best person for someone to be talking to about getting this advice? Is it their oncologist? Is it their GP? Is it a gynaecologist? Or is it different?
It's a menopause specialist.
A menopause specialist.
Yes.
I think that's really important, because I think that's
Definitely.
where people struggle sometimes.
Yes.
Who do I talk to?
Yes, and I mean, there's no way that and of course, some GPs will be menopause specialists. So that's great. And they're increasing in number, of course. So if you're lucky enough in your practice to have a GP who has an advanced menopause specialist training, that's great. But I wouldn't expect oncologists to be expert on this, because they've got to be expert in so many other things. And the same with the breast surgeons. So medicine is a very big subject.
Yeah, absolutely. Well, I just want to say a huge thank you, Dr. Karen, for joining us today. Really appreciate your time. Really appreciate everyone sharing, and the wonderful, as Sarah said, the wonderful support everyone's giving each other. One of the things we hear from so many people going through menopause and going through the cancer treatments we've been talking about is knowing you're not on your own and being able to talk to other people is so important. So just want to say a huge thank you to everyone for joining us, and really appreciate your time today. Thank you.
Not at all. Very nice to see you.
Thank you.